very good afternoon. So I'll be presenting on the topic, I am Dr. Sumit Randhir Singh. I'll be presenting on the topic delayed rhegmatogenous retinal detachment post-macular surgery, a multicentric study. So we all know that macular surgeries for indications such as full thickness macular hole and ERM represent up to a quarter of total retinal surgeries. Rhegmatogenous retinal detachments post-macular surgeries usually necessitates a resurgery, and it can happen in approximately 1 to 3% of the patients. Considering the rarity of delayed RRD post-macular surgery, there is very limited knowledge about the possible causes, clinical features and the outcomes of these patients. Therefore, we undertook this study, and here we report the anatomical and the visual outcomes of eyes who developed delayed RRD post-macular surgeries. So our inclusion criteria was the patients who developed RD post at least 3 months after macular surgeries. So we did an anatomical as well as functional assessment in which we studied the best corrected visual acuity at pre and post operative stage. We studied the indications and the details of both the macular as well as the RRD surgery, the time interval from macular surgeries to RRD diagnosis, the location, extent of RRD and the nature of the retinal break, and the post-op outcomes defined as the anatomical as well as functional success. So these are some of the results. We noted that delayed rhegmatogenous retinal detachment happened in 16 out of 2,906 eyes who underwent macular surgeries. So this is a prevalence rate of 0.55%, and this happened after a mean period of 8.4 months. Intraoperative peripheral retina evaluation during the RRD repair, that is the second surgery, what was noted that missed or de novo breaks were probably the culprit in 11, that is around 69% of the eyes. No break was identified in 2 eyes, 12.5%. GRT, that is more than 3 clock hours of retinal tear, was present in 2 eyes, and one of the patients had a retinoschisis related retinal break. So this table 1 shows the visual outcomes and the details of the macular surgery, which is the primary first surgery. So the primary indication for the surgery was ERM and full thickness macular hole in 8 eyes. The baseline visual acuity was 0.6 logmar units. In majority of the patients, the tamponade used was either air, SF6 or C3F8 gas. Additional procedure in terms of endo laser was done in 4 eyes, and what was noted that the vision improved from 0.6 to 0.4. This was before the diagnosis of the reg-RD, and these patients were followed up over a period of 8.4 months. This table 2 shows the patients who developed RRD post-macular surgeries. So we note that the vision suddenly deteriorated to 1.8 logmar. In these patients, 7 patients had to be, silicone oil had to be inserted in these eyes, and among these 4 patients had even encircling band. These patients were followed up for 4 months. So in total, the total follow-up was 12.8 months for these patients, and subsequently post-RD repair, the BCVA improved to 0.9 logmar. So the anatomical success defined as attached retina after 1 surgery was seen in 14 eyes, that is 87% of the eyes. And the functional outcome, so this is the best corrected visual acuity at baseline prior to the macular hole surgery was 0.6, that is 20/80, and it improved, and sorry, it worsened to 20/160 at post-RD repair. So these are after 2 surgeries. So we see that among these 16 eyes, 5 eyes showed improvement of 0.5 logmar, 3 eyes maintained the baseline visual acuity, whereas 8 eyes had a loss of vision in terms of logmar unit by 0.8 units. So this is one of the representative figures. Figure A shows the presence of ERM for which the primary macular surgery was done. We see there is a presence of ERM, some cystoid spaces. Subsequently at follow-up, the patient developed reg-RD. Retinal surgery was done. And in figure C, we see the presence of a posterior encircling band. The retina appears attached, and the OCT shows some amount of RPE undulations and attached retina. So coming on to the discussion, we know that multiple mechanisms can be involved in the development of RRD. Among these, the prominent ones are the missed or iatrogenic peripheral retinal break. Some of the breaks also happen post the first surgery, that is de novo breaks, because PVD is not complete in all the macular surgery eyes. So post progression of PVD, and there can also be some amount of vitreous incarceration at the site of the previous sclerotomies. So we note that even though visual acuity improved after RD repair, however, it was still significantly less than the baseline visual acuity. This highlights the role of peripheral retinal examination during the primary macular surgery. So to conclude, RRD post-macular surgeries can happen because of either a missed or a de novo retinal break, and 50%, at least half of the eyes, show a worse visual acuity compared to the baseline despite a successful retinal reattachment. Thank you.
Thank you, Dr. Sumit. Any questions from the audience? Any, Dr. Bhatia, any questions?
Dr. Sumit, I
Manisha?
have a few questions.
Yeah, please.
You said it's a multi-centric study, so how many centers have participated? In
There
this?
were 13 centers, one of which is my center where I am working, and 12 were outside India. So it was from Italy as well as from US.
The second thing is that, when you say that the probable cause of the RRD could be the breaks which have been missed, but I would assume that they would cause an RD within 3 months of having done a macular hole surgery.
Yeah, that's why the probable word, because we are not able to ascertain what's the cause, either a sclerotomy related break or the progression of PVD or any other missed break. So etiology wise it's very difficult to ascertain. That's why de novo bar missed break.
Were these cases of macular hole, they underwent a complete vitrectomy or a limited vitrectomy during the first surgery?
So because multiple surgeon and multiple nationalities were involved, so I don't think that all macular hole cases they undergo a complete vitreous based shaving as we do in a
So I think that's a very important factor, because as you also mentioned in one of your slides that probably the PVD induction is continuing to happen after the macular hole surgery.
Yes.
And we would assume, because I don't think any one of us have that experience where we would have encountered an RRD after a macular hole surgery just because there's a vitreous incarceration sclerotomy. I think with MIVS it's become very safe.
Well established.
So probably these are those cases where a complete vitrectomy has not been done, and the PVD continues to get extended and probably results in some fresh breaks. GRT, of course, when we are having a reuse of instruments, probably sometimes we do land up where there is an undue traction in the periphery. But otherwise, I think that could be the only possible reason I can think of if they have not undergone a complete vitrectomy during the primary surgery.
Only interesting thing was like all of these causes will lead to a RD within first 3-4 months.
Absolutely.
So these patients were the ones
PVD induction, of course, can cause it later on as well.
Develop over months.
Dr. Dipinder, I think,
Yes,
have a
one
point to
question
make.
from audience.
I just wanted to, that intraoperative, I think steps could have been charted, and
Dr. Kanika.
whether PVD induction was done, because some ERM cases have pre-existing PVD, and some cases you induce PVD.
Because this was a retrospective study and 2,900 patients, so it was very difficult to meticulously pinpoint the points like what was done pre-operative, like intraoperatively in all the patients.
Right.
Also, I think just one comment, I think I saw your chart and you used SF6 for GRT cases, especially in a recurrent case. I think that's really,
This was one of the US patients, I think.
yeah, because that's very bold, I think.
Thank you.
Thank you, boss.